Good day, everyone. So today, we will be talking about neurovascular assessment, pupillary assessment, Glasgow Coma Scale, and cranial nerve assessment. So these are important because, as we all know, health assessments are a key part of a nurse's role and responsibility. So with these assessments, we are able to learn about our patient's concerns, symptoms, and overall health. We can also notice signs of potential or underlying health issues that need to be addressed as well. So here are our course learning outcomes. My name is Dixie Ikong and I will be reporting on the neurovascular assessment. So first and foremost, let us define these following terms. Neurovascular assessment. This is the assessment of the peripheral circulation and the peripheral neurologic integrity. This is done in order to check for any neurovascular impairment, which is usually caused by pressure on the nerve or altered vascular supply to the extremity. Compartment syndrome. This is the increased pressure within a confined space, examples of which is a cast or a muscle compartment, which compromises blood flow and tissue perfusion. If action is not taken immediately, ischemia and potentially irreversible damage to the soft tissues can occur. Paresthesia. This is a burning, tingling, or numbness sensation that may be caused by pressure on nerves or by circulatory impairment. This is usually caused by soft tissue swelling or direct trauma. So why is a neurovascular assessment important? This is in order for us to assess for adequate nerve function and circulation to the parts of the body in order to detect signs and symptoms of potential complications such as compartment syndrome, to evaluate vascular and neurological integrity of an extremity, to be able to recognize early signs of neurovascular deterioration or compromise, to support assessment and prevent permanent damage to the limb, to determine clinical risk factors that may lead to neurovascular deficits, loss of functions, and even death. And lastly, to aid in diagnosis, treatment, management, and referral. Patients who require neurovascular assessment include but are not limited to the following: musculoskeletal trauma to the extremities such as fractures and crush injuries, post-operative, internal or external fixation of fractures. So a fracture fixation is when a bone is broken or fractured and the pieces are out of alignment or potentially unstable. So they need to be moved back into position and stabilized. This is sometimes referred to by patients as having the bones reset. Orthopedic surgery, spinal surgery, plastic surgery on extremities or phalanges, cardiac catheterization, and tourniquet applied for long periods. Application of plaster cast, such as a restrictive dressing, application of traction, may it be skin and skeletal traction. So a traction is the application of a pulling force to an injured part of the body or extremity. It often is done using pulleys and weights, or even application of splints, bandages, or adhesive tapes to the skin. A traction limits movement and reduces the fracture to help decrease pain, spasms, and swelling. It also aims to restore and maintain straight alignment and length of the bone following fractures. Burn patients such as circumferential burns and signs of infection in the limb. Next, we have the different parameters, method of exam, and interpretation of its results. So the first parameter is pain. Use a pain assessment tool to assess severity of pain. A score of 0 indicates no pain, 1 to 3 indicates mild pain, 4 to 6 indicates moderate pain, and 7 to 10 indicates severe pain. In sedated patients or those who can't verbalize information, be aware of nonverbal pain cues. Indication of pain in nonverbal patients includes restlessness, grimacing, guarding, tachycardia, hypotension, tachypnea, or diaphoresis. Also note the characteristics of pain as what we've discussed in our previous semester in the concept of pain. The second parameter is the sensation. So first, we have the radial nerve. Palpate the webbing space between the thumb and the index finger, including the dorsal surface of the hand. So as you can see in the picture, it is pointed by the arrow in the color violet. So the patient should be able to feel touch with the first web space of the hand between the thumb and the index finger. Next is the median nerve. Palpate the webbing space between the thumb and index finger, including the palmar surface of the hand. The patient should be able to feel touch at the distal aspects of the thumb to the mid-ring finger. Sensation should also be present on the surface of the palm, extending to the thumb and mid-ring finger. Next, we have the ulnar nerve. Palpate between the little finger or the pinky and the distal ring finger on the palmar and dorsal surface of the hand. The patient should be able to feel touch at the anterior and posterior aspects of the pinky and the mid-ring finger, down to the palm and dorsum aspect of the hand. Tibial nerve. Palpate the plantar surface of the foot. The patient should be able to feel touch at the medial and lateral surfaces of the sole of the foot. Peroneal nerve. Palpate the dorsal surface of the foot. The patient should be able to feel touch on the dorsal aspect of the foot. The third parameter is the motor function. So again, we have the radial nerve. Extend the wrist and fingers at the knuckle joint. If a cast is over the hand, only assess the extension of the fingers. The patient should be able to hyperextend the thumb and fingers. Next, we have the median nerve. Bring the thumb and the pinky together so they are touching each other. The patient should be able to oppose the thumb and the small finger and flex the wrist. Ulnar nerve. Abduct all the fingers. The patient should be able to abduct all fingers, especially the little finger. Tibial nerve. Plantar flex ankle and toes. The patient should be able to plantar flex the ankle and toes. And lastly, the peroneal nerve. Dorsiflex the ankle and toes. The patient should be able to dorsiflex the ankle and extend the toes at the metatarsophalangeal joints. For the next parameter, we have perfusion. So for skin color, compare the color of the skin bilaterally. Always consider the patient's usual skin tone and any skin conditions. Cyanosis can present differently in different skin tones. Normally, the skin color is pink or the patient's natural skin tone. Pallor or cyanosis may indicate inadequate arterial supply. Dusky, cyanotic, mottled, or purple-black coloration may indicate inadequate venous return. Shiny and pale skin may indicate pressure in the affected area and may also be a sign of compartment syndrome. To assess for skin temperature, use the back of your hands to assess skin temperature bilaterally. Normally, the skin temperature is warm to touch. If it is cool or clammy, it may indicate inadequate arterial supply. If it is too warm or too hot, it may indicate inadequate venous return. Next, we have the capillary refill time or the CRT. Press on the nail beds to evaluate the peripheral vascular perfusion. Note how long it takes for the distal capillary bed to regain its color after pressure has been applied to cause blanching. So, as you can see in the picture, this is how to assess for the capillary refill time. Normally, it would take about less than or equal to 2 seconds. However, if the CRT is prolonged, it may indicate an abnormal perfusion. For swelling, compare swelling of unaffected limb to the affected limb. Check for pitting by applying pressure on the edematous area. So pitting edema is when indentation remains in the edematous area after pressure is applied. So as you can see here in the picture. Palpate or ask the patient if there is any tightness on the affected area, as skin may present tight and shiny. Check if there are changes in skin temperature and color. So when there is swelling, there is warmth upon palpation, and redness can also be inspected. Limb circumference measurement can also assist in monitoring swelling. When measuring, mark the level or levels on the limb to ensure accurate serial recording. And lastly, for the perfusion, we have the pulses. Palpate the upper extremity peripheral pulses, the brachial, radial, and ulnar, and the lower extremity peripheral pulses, the femoral, popliteal, posterior tibialis, and dorsalis pedis, bilaterally, using the pads of your middle and index fingers, applying gentle pressure. Use a 0 to 4 point scale, noting also if the pulse is weak, diminished, or absent. For the 0 to 4 point scale, 0 as having an absent or no palpable pulse, 1 plus as having faint but detectable pulse, 2 plus having slightly more diminished pulse than normal, 3 plus normal pulse, and 4 plus bounding pulse or a strong pulse. A manual Doppler scan should be utilized if a pulse palpation site is challenging to find or if the pulse is weak, as seen in the picture. If pulses are not palpable due to plaster cast perhaps, assess closely the parameters that are close to the pulse. Now for the guidelines. Explain the importance of neurovascular assessment and why it must be performed. Prior to assessing the patient's neurovascular status, ensure that the nail polish, dirt, blood, or any stained skin preparation is removed from the distal extremities. Any jewelry should also be removed from the injured or affected limb, as it may cause constriction due to expected swelling. And there should always be an adequate or full light. Assess for all mandatory parameters as what we have discussed earlier, and always perform bilateral assessment for comparison and documentation. Make the patient as comfortable as possible. Provide reassurance and information. This is very important to the patient and to the significant others as well in order to help reduce anxiety during the procedure. Evaluate by comparing the neurovascular status with previous readings if available and identify any changes. Record the observation in neurovascular assessment form immediately after assessing patient's neurovascular condition. Ensure that all documentation is complete. Include neurovascular assessment findings of all extremities in documentation. And lastly, notify the physician immediately if any alterations in neurovascular assessment occurs. Next is the normal and abnormal findings. First, I will be discussing about the normal findings of each parameter to be followed by Mr. Nunez for the abnormal findings. First parameter is pain. A normal finding would have a score of 0, indicating no pain. The client would report no pain at rest and on passive movement, especially on extension or flexion of the extremity, particularly for the affected muscle group, and no nonverbal pain cues. For the second parameter, which is sensation, the client reports no changes in sensation such as numbness or tingling in the extremity. The client is also able to identify two close points on a small area of skin during a 2-point discrimination test. The radial nerve, median nerve, ulnar nerve, peroneal nerve, and tibial nerve has normal findings as reported earlier. Motor function. Still, normal findings are the same as stated earlier in the report. And lastly, perfusion. For the skin color, it is pink or the natural skin tone of the patient. For the skin temperature, it is warm to touch. Capillary refill time must be less than or equal to 2 seconds. Swelling, skin does not present tight and shiny. And for pulses, pulsation is equally strong bilaterally with regular intervals between beats. So once again, this is Dixie Ikong to be followed by the next reporter, Mr. Nunez.
Good morning everyone, my name is Thomas Miguel R. Nunez and today I'm going to be reporting of the abnormal findings. Before I begin, I would like to thank Ms. Ikong for the wonderful reporting for the normal findings. So, first we have the parameter of pain. So a pain score of 1 to 3 indicates mild pain, while a pain score of 4 to 6 indicates moderate pain. Lastly, a pain score of 7 to 10 indicates severe pain. And then for the nonverbal pain cues, we have facial grimace, guarded movement, tachycardia, and diaphoresis. So these are the nonverbal pain cues. Next we have for sensation, paresthesia. This is tingling and numbing sensations that can indicate compromised blood flow or nerve function in the area. And then paralysis, it is a late finding of nerve damage in which there is a complete absence of pain or any feeling on the area. Next we have the motor function. So first we have the radial nerve. An abnormal finding for assessment of the radial nerve is that the wrist and fingers are unable to extend at the knuckle joint, and it shows decreased motor function. And the next we have median nerve. So the thumb and little finger will be unable to join together, showing compromised motor function. And then we have the ulnar nerve. This is when the fingers are unable to abduct if there is damage in this nerve. And then for the peroneal nerve, ankles and toes won't be able to dorsiflex if there is peroneal nerve problems. And lastly, for the tibial nerve, ankles and toes won't be able to plantar flex if there are problems in the tibial nerve. And then now for the parameter of perfusion. First, for the color, pallor or cyanosis alludes to insufficient arterial blood perfusion. Purple-black or cyanotic discoloration can indicate insufficient venous return. Shiny, pale skin indicates pressure in the area and can be a sign of compartment syndrome. For temperature, cool skin indicates insufficient arterial supply, while warm skin indicates poor venous return to the heart. Capillary refill time exceeding 2 seconds is indicative of abnormal perfusion. Swelling indicates presence of edema due to buildup from leaking capillaries. For pulses, weak, diminished, or absent pulse can indicate tissue death. Now for the nursing responsibilities. Before, you must always perform necessary hand hygiene to prevent cross-contamination and nosocomial infection, and then gather necessary equipment to save time and energy. Explain procedure to the client to ease anxieties and build rapport. Instruct the client to get into a comfortable position. Allow client to change into loose clothes for comfort, and ensure there is sufficient or natural lighting to better inspect the color. During, maintain client's privacy throughout the whole procedure. Start with extremities farthest from you. Correction. Always ask before touching the client. Work in an organized manner, taking a head-to-toe distal to proximal approach. Monitor the client's responses throughout the assessment. Monitor client's level of comfort throughout the assessment and mention words of encouragement throughout. After, document findings. Validate findings to ensure they aren't anomalous. Assist the client in standing or sitting back up. Report severely abnormal findings to the physician. Compare updated neurovascular assessment findings to assessments done previously, and then do aftercare. Now I'm going to be talking about pupillary assessment. First, we have the definition of terms. So first is direct light reflex. This is the pupillary response of the eye to light directly entering the same eye, so ipsilateral. Left direct pupillary reflex refers to the response of the left eye to light shining in the left eye, while right pupillary reflex is the response of the right eye to light entering the right eye. On the other hand, consensual light reflex is pupillary response of the eye to light entering the opposite eye or the contralateral eye. Left consensual light reflex is the response of the left eye to light entering the right eye, so it's the opposite. And right consensual light reflex is the response of the right eye to light entering the left eye, so it's opposite. It's opposite. Next, we have anisocoria. This is a condition in which the pupil of one eye is a different size to the pupil of the other eye. This usually results in blurred, double, or loss of vision. Causes may include ocular trauma, intracranial bleeding, and optic nerve inflammation. Now, I will discuss the physiology of pupillary reactions. So the eyes allow us to receive light stimuli for an environment to be processed as images in the brain. The pupils specifically, they serve as the gatekeeper of the eyes, so their size determines the amount of light that enters the eye. This is done through the action of the iris sphincter muscles, namely the sphincter pupillae and the dilator pupillae. As light enters our eye, it passes through the cornea, pupil lens, and eventually the retina, where light is converted to nerve impulses to be sent to the brain through the optic nerve, as we know from anatomy in first year. So if the client is in a well-lit room with lots of light, and light is directly going to their eyes, the brain processes this and signals the iris sphincter pupillae to contract, and in turn the pupillary constriction occurs to limit the amount of light entering the eye. So the muscle responsible for constriction is the sphincter pupillae, correct? In a dim room, however, with very little light, the brain signals the iris dilator pupillae to contract, causing pupillary dilation to allow as much light as possible into the eyes. So these are the two muscles, the sphincter pupillae and the dilator pupillae. Next is the purpose of pupillary assessment. So first is to assess for injury to the optic nerve, oculomotor nerve, damage, lesions in the brainstem, including abnormal growths like tumors, and the effects of medications like barbiturates. To evaluate the extent or presence of brain injury or hemorrhage, because the eye is very directly linked to the brain. Now for the indications. First, we have suspected brain injury. This is because after head trauma, it is important to assess whether brain injury has occurred, and this can be done through pupillary assessment. Next is intracranial hemorrhage. Excuse me. So severe bleeding within the cranium can cause pressure on the brain to build up, which can lead to brain damage. As a result, the pupillary assessment should be done to evaluate brain damage. Cataract. In patients with cataract, the pupil often does not dilate as well. This is especially important in patients about to undergo cataract surgery, as the pupils will have to be dilated fully to expose the lens. So this is to check pre-surgery if the client will be able to handle the surgery. Conjunctivitis. Patients with conjunctivitis need to have pupillary assessment to evaluate the extent of inflammation and its effect towards the accessory eye structures. Use of illicit drugs. Pupillary assessment is done to patients who have used illicit drugs, because these drugs often have effects on the ability of the eye to dilate or constrict. So as you can see in this picture, where the eye is super red and it's super dilated and super droopy, maybe that person has done drugs. That's why you have to check. So next we have central retinal artery occlusion. The central retinal artery supplies blood to the optic nerve, which is part of the pathway between the pupils and the brain. Therefore, occlusion of this artery can be detrimental to pupillary function, and pupillary assessment must be done. Next is optic neuritis. So optic neuritis is the inflammation of the optic nerve, hence the term neuritis. Therefore, pupillary assessment has to be done to evaluate the extent of the inflammation. And then lastly is Horner syndrome. So this condition affects the nerve supply to the eye, and so pupillary assessment can help determine its effect on the pupils. So here in this picture of the man with one eye that's drooping, that is a symptom of Horner syndrome. Next, or lastly rather, for me, is the guidelines. So first, observe the size, shape, and equality and position of the pupils before starting, just to see if there are any clearly visible things that are abnormal in the eye before you go into it, or into the assessment rather. And then next is conduct assessment in a dimly lit room, so that you can control the amount of light that is entering the eye, because if there's too much light, then it can affect the results. So that's another variable to control. Instruct the client to fixate their focus on a distant object, so that other reactions or conditions such as anisocoria may be observed in conjunction with the pupillary light reflex. Next is maintain calm and composure so as to not startle the client, as this may cause psychosensory stimulation that can interfere with the findings. So if you're too loud, or if you suddenly shout at the client, they might get startled, and this can change the results of the assessment. So be aware of that. Next, when assessing pupillary size, shine the light from below the face. So here you can see in the first picture with a check mark, the light is nice and it's below the face. And the second one is like right at the face, so it's not really gonna allow you to see any changes because the light is already on the face. So this is why from below you slowly elevate the pen light to the level of the eyes and closely monitor the pupil's reaction several times on both eyes. So with this, I will now be passing you over to my amazing colleague, Ms. Siniza. Thanks everyone, have fun!
Hi, I am Stephanie Sinisa and I'll be continuing the report for the papillary assessment. So to start off, let us discuss the normal and abnormal findings. So first, for our pupils, we have to check for the size and shape. So we have to do this by measuring our pupils against a gauge that would indicate the specific size of our pupils. So for the normal findings, pupils should be round with a regular border centered in the iris, normally equal in size 3 to 5 mm. For the abnormal finding, so we have here anisocoria. This is where your pupils is of unequal size. This is caused by impaired parasympathetic nerve supply to the iris, oculomotor nerve paralysis, and paralysis of the cervical sympathetic nerves. Next is mydriasis. So this is where your pupils are dilated and fixed, and this is typically resulting from central nervous system injury, circulatory collapse, or deep anesthesia. So next is to test for the papillary reaction to light. So test for papillary response by darkening the room and asking the client to focus on a distant object. To test direct pupil reaction, shine a light obliquely into one eye and observe the papillary reaction. So the normal finding is that the normal direct papillary response is constriction. So for the abnormal finding, so when light directed at the blind eye results in no response in either pupil, monocular blindness can be detected. So there's also another factor if the eyes will not constrict, and that is drug-induced mydriasis. So pupils are dilated bilaterally. Pupils may or may not have a reaction to light stimulus. So next is to assess for the consensual response. So at the same time as direct response, by shining a light obliquely into one eye and observing the papillary reaction in the opposite eye. So the normal finding is the normal consensual papillary response is constriction. And for the abnormal finding, pupils do not respond to direct and consensual pupil testing at all. So test for the accommodation of the pupils. So accommodation occurs when the client moves his or her focus from a vision of from a distant point to a near object, so causing the pupils to constrict. Hold your finger or pencil about 12 to 15 inches from the client. So the normal finding, the normal pupillary response is constriction of the pupils and converge of the eyes when focusing on a near object. The abnormal finding is the pupils do not constrict, eyes do not converge. Next is for the nursing responsibilities. So before doing the papillary assessment, we have to explain the procedure to the client. So this is so that the client can understand what the procedure is all about and what to expect, and at the same time gain their trust. Next is undertake pre-procedure checks to ascertain if there are any pre-existing irregularities with the client's eyes or factors that can influence papillary assessment findings. So check if the client has already pre-existing irregularity with the pupils like cataracts, false eyes, or previous eye injury, and is taking medication that can cause papillary dilation like your tricyclics, atropine, and sympathomimetics, and medication that causes papillary constriction like your narcotics and topical beta blockers. Next is we have to gather necessary equipment, and if possible, dim the overhead light source. Dim light will facilitate a better view of the pupils and their reaction to light. wash and dry hands to prevent cross-contamination, and instruct the client to go into a comfortable position. So during the popularity assessment, we have to maintain the client's privacy throughout the whole procedure. Note the size of each pupil. So if available, use the scale printed on the neurological assessment chart as a comparison. And always warn the patient if you will move your pen light to check the other eye. So move the pen light from the side of the head towards the pupil. So to test for direct pupil reaction, shine a light obliquely into one eye and observe the pupillary reaction. To test for consensual response, avoid shining the light into the other eye and observe whether the opposite pupil also reacts. And when testing for consensual response, place your hand or another barrier to light between the client's eyes to avoid an inaccurate finding. And to test for accommodation, hold your finger or a pencil about 12 to 15 inches from the client. Your responsibilities after is to document findings, report any abnormal findings to the physician, and do aftercare. So our next topic is the Glasgow Coma Scale. So for the definition of terms, first we have aphasia. So aphasia is an acquired communication disorder due to stroke, brain injury, or a neurological disorder called the primary progressive aphasia. So what happens here to the person with aphasia, there's an impaired ability to process language, but it doesn't affect their intelligence. So they are still just as smart, though they may have problems understanding language, speaking, reading, or writing, both verbal and written. So when communicating with a person with aphasia, we have to be patient and allow plenty of time for a response. We have to use simple and short sentences and make sure that we go to a quiet place once we speak to them so that there won't be a lot of distractions. So people with aphasia can also use iPads or pen and paper to draw the message that they want to convey, and if they have hard time formulating words or coming up with a word, they could use gesture. Next is aphasia. So aphasia is a neurological disorder characterized by the inability to perform learned movements on command, even though the command is understood and there is a willingness to perform the movement. So both the desire and the capacity to move are present, but the person simply cannot execute the action. So one form of aphasia makes a person unable to voluntarily perform certain movements involving the facial muscle. For instance, they may not be able to lick their lips or wink, and another form affects a person's ability to intentionally move the arms and legs, and another person also finds it difficult or impossible to move his or her mouth and tongue to speak. So people with aphasia should undergo therapy wherein it could help them improve their speech coordination, since in the therapy they will be taught to repeatedly practice the formation and pronunciation of sounds or words. And also with extreme cases of aphasia, learning sign language could be beneficial. Next is decerebrate. So this is an extended type of posture that can indicate damage to the brain stem. So notice that the person has his arms adducted and extended. The hands are in a pronation position and the fingers will be flexed, along with the legs which will be extended, and then the feet are plantar flexed. So to remember decerebrate, just remember that decerebrate has a lot of E meaning extension of the arms. Next is decorticate. So this is a flex positioning and it can indicate damage to the cerebral hemisphere. So the client would have his arms adducted and flexed. The hands will be closed shut and flexed. The legs are internally rotated and the feet are in plantar flexion. So to easily remember decorticate, core, the word core, so pay attention to the arms. core, meaning the patient will bring their arms to the core or the middle of their body. So next is the purpose of Glasgow Coma Scale. So first is it addressed the three areas of neurologic functioning, such as the eye-opening response. So you have to check if do they open their eyes spontaneously like normal. Verbal response, so does the person talk normally or do they know who they are and where they are? Motor response, are they able to follow the command that is given to them? The next purpose is that it gives an overview of the patient's level of consciousness. So in the Glasgow Coma Scale, with three areas of neurologic functioning, there are specific scores allotted for each area. So once we tick them off and total the score, highest possible score would reflect that the client is fully alert, aware, and oriented, and the lowest possible score would be unconscious and unresponsive. And the last purpose for the Glasgow Coma Scale is that it evaluates the neurologic status of patients who have had a head or brain injury. So for the levels of consciousness, first is we have full consciousness. So the client is awake and alert and it's oriented to the time and place. Confused, so the client is disoriented to the surroundings and has an impaired judgment. So we may need to give them a few cues so that they could respond to the command that we will give to them. Next is lethargy, so the client is drowsy. So the client needs a gentle verbal or touch stimulation to initiate a response. Next is obtunded, so the response is slowly to external stimulation and it needs repeated stimulation to maintain attention and response. And stuporous, so the response is only minimal with vigorous stimulation and may only mount as a verbal response. And comatose, no observable response to any external stimulation.
Good morning, everyone. I'm Miss Celestial, and I'm here to continue the report of Glasgow Coma Scale assessment. The indications of Glasgow Coma Scale are the following: falls, neurological disease process like stroke, brain tumor, epilepsy; traumatic brain injury, hypoxia, vascular injuries or infection, metabolic imbalances such as hypoglycemia, hepatic or renal failure, and diabetic ketosis. The brain is highly metabolic and requires a constant supply of oxygen and glucose for neuronal perfusion and functioning. The next is the limitations. There are multiple limitations that can alter the score and not provide an accurate picture of the patient's brain injury. The client is intubated and cannot speak. Eyes are swollen closed. The client is unable to communicate in English. The client has a hearing loss. The client is blind. The client is asphaxic. The client is paralyzed or hemiplegic. Low blood oxygen, impairment from drug use, alcohol intoxication, and traumatic shock. The next is the normal and abnormal findings of adult Glasgow Coma Scale and pediatric Glasgow Coma Scale. The Glasgow Coma Scale is the most common scoring system used to describe the level of consciousness in a person. So basically, it is used to help gauge the severity of an acute brain injury. The test is simple, reliable, and correlates well with outcome following severe brain injury. The normal score of the adult Glasgow Coma Scale is 13 to 15, which is mild, while the abnormal score of the adult is 9 to 12, which is moderate, and 8 or less indicates coma and severe. Pediatric brain injuries are classified by severity using the same scoring levels as adults. The normal score of the pediatric Glasgow Coma Scale is 13 to 15, indicates a mild TBI, and moderate injury, which is 9 to 12, while the abnormal score is 8 or lower, reflecting the most severe. As in adults, moderate and severe injuries often result in significant long-term impairments. As you can see in the picture, there are a little bit of difference between the adult and pediatric Glasgow Coma Scale. There are 3 assessments that you need to take note: the eye response, best verbal response, and best motor response. In eye response, 1 indicates no eye opening, 2 indicates opening to response to pain to limbs as above, 3 indicates eye opening in response to any speech or shout, not necessarily request to open eyes. 4 indicates spontaneous eye opening. The best verbal response record best level of speech. 1 indicates no verbal response, 2 indicates incomprehensible speech like moaning but no words. In pediatric, inconsolable and agitated. 3 indicates inappropriate speech, random or exclamatory articulated speech but no conversational exchange. In pediatric, inconsistently inconsolable and moaning. 4 indicates confused conversation. The patient responds to questions in a conversational manner but some disorientation and confusion. In pediatric, cries but consolable and inappropriate interaction. 5 indicates oriented to the person, place, and time. The patient knows who he or she is, where he or she is and why, the year, season, and month. In pediatric, smiles, oriented to sounds, follows objects, and interacts. The next one is the best motor response. It applied varied painful stimulus. 1 indicates no response to pain, 2 indicates abnormal extension. The stimulus causes limb extension, like the abduction, internal rotation of shoulder, pronation of forearm, and wrist extension. 3 indicates abnormal flexion. Stimulus causes abnormal flexion of limbs, like adduction of arm, internal rotation of shoulder, pronation of forearm, and wrist flexion. 4 indicates flexion withdrawal from pain. Pulls limb away from painful stimulus. In pediatric, withdraws from pain. 5 indicates moves and locate pain. Purposeful movements towards changing painful stimuli is a localizing response. In pediatric, withdraws from touch. 6 indicates obeying command. The patient does simple things you ask. The next, the nursing responsibilities before, during, and after using the Glasgow Coma Scale. Before, explain the procedure to the patient, ascertain the patient's acuity of hearing, check the patient's medical history that may affect the accuracy of the Glasgow Coma Scale, and do medical hand washing. During, in eye opening, observe the eye without speaking to the client. If the eyes are closed, call the client's name. If no response is noted, raise your voice. In motor response, observe if the client will be able to follow the command that is being instructed. In motor activity, observe if the client can cooperate with testing. In verbal response, assess the client's orientation to self, environment, and time. In vital signs, do vital signs to the patient every 15 minutes. Assist the patient in doing the assessment and ensure the client's safety in doing the assessment. After, total the points for each part and compare the score obtained with the client's baseline score. Record the best response of the patient while also recording any abnormalities. And lastly, assist the patient in a comfortable position after doing the assessment. The next assessment is the cranial nerve assessment. First, we must define the following terms. The first and the second one are the smell disorders include a loss in ability to smell or changes in the way odors are perceived. So anosmia, known as loss of smell, means no odors can be detected. Hyposmia is a decreased sense of smell or a decreased ability to detect odors through your nose. Nausea, the perceptive faculty enabling one to recognize the form and the nature of people and things, the faculty of perceiving and recognizing. Stereognosis is the ability to recognize and identify common objects through tactile manipulation without the use of visual cues. Ptosis, the upper eyelid droops over the eye. The eyelid may droop just a little or so much that it covers the pupil. Ptosis can limit or even completely block normal vision. Nystagmus is an involuntary rhythmic side-to-side, up and down, or circular motion of the eyes that occurs with a variety of conditions. The next is the purpose of cranial nerve assessment. Cranial nerve assessment, it is used through physical examination to recognize problems with the cranial nerves. Each test is designed to assess the status of one or more of the 12 cranial nerves. So these components correspond to testing the sense of smell, visual fields and acuity, eye movements and pupils, sensory function of face, strength of facial and shoulder girdle muscles, hearing, taste, pharyngeal movement and reflex, and lastly, the tongue movements.
Good day everyone, I am Andrein P. Tumulak and I will be discussing the indications, contraindications, normal and abnormal findings of the cranial nerve assessment and the nursing responsibilities before, during, and after the cranial nerve assessment. Indications for a cranial nerve assessment. Patients with head, facial or dorsal neck pain or head, neck or spinal injury, patients with altered movement patterns, example, patients who are unsteady or have slow movements, tremors or twitching of facial muscles, patients with muscle weakness or wasting, patients with slurred or altered speech patterns or drooling or difficulty in swallowing, patients with paresthesia, example, tingling, pricking, burning, and numbness, or change in somatosensation, example, altered hot or cold, sharp or dull, or light touch sensation, and patients who have experienced change or alteration in sense of hearing, example, hearing loss or buzzing in ears, sight, example, blurry vision, diplopia, or visual field changes, or patient who have experienced change in smell, example, anosmia, and patients who have experienced change in taste, and patients who have experienced vertigo, fainting, dizziness, or seizure. Contraindications for a cranial nerve assessment. Patients who have alteration in level of consciousness and immunocompromised patients because clients are not as awake, alert, or able to understand or react as we are normally. Normal and abnormal findings for a cranial nerve assessment. Test for cranial nerve 1, olfactory. Instruction. Ask the client to clear the nose to remove any mucus, then close eyes, occlude one nostril, and identify a scented object that you are holding such as soap, coffee, or vanilla. Normal findings. Client correctly identifies the scent presented to each nostril. Take note that some older clients' sense of smell may be decreased. Abnormal findings. Inability to smell or identify the correct scent. Test for cranial nerve number 2, optic. First, use a Snellen chart to assess the vision in each eye. Normal findings. client has 20/20 vision in the right eye and left eye. Abnormal findings include difficulty in reading the Snellen chart, missing letters, and squinting. Second, ask the client to read a newspaper or magazine paragraph to assess near vision. Normal findings, client reads print in 14-inch without difficulty. Abnormal findings, client reads print by holding closer than 14-inch or golds print farther away, as in presbyopia, which occurs with aging. Third, assess visual fields of each eye by confrontation. Normal findings, clients have full visual fields. For abnormal findings, loss of visual fields may be seen in retinal damage or detachment, with lesions of the optic nerve or with lesions of the parietal cortex. Fourth, use an ophthalmoscope to view the retina and optic disc of each eye. Normal findings, round red reflex is present. Optic disc is 1.5 mm, round or slightly oval, well-defined margins, creamy pink with paler physiologic cup, and the retina is pink. Abnormal findings, papilledema or swelling of the optic nerve results in blurred optic disc, margins and dilated, and then pulsating veins. Test for cranial nerve number 3, oculomotor, and cranial nerve number 4, trochlear, and cranial nerve number 6, abducens. First instruction, inspect margins of the eyelids of each eye. Normal findings, eyelids cover about 2 mm of the iris. Abnormal findings, ptosis or the drooping of the eyelid is seen with the weak eye muscles such as in myasthenia gravis. Second instruction, assess extraocular movements. If nystagmus is noted, determine the direction of the fast and slow phases of movement. Normal findings, eyes move in a smooth, coordinated motions in all directions, the 6 cardinal fields. Abnormal finding, the nystagmus or the rhythmic oscillation of eyes. It is a cerebellar disorder. In the limited eye movement through the 6 cardinal fields of gaze, it is an increased intracranial pressure. Third instruction, assess pupillary response to light, direct and indirect, and accommodation in both eyes. Normal findings, bilateral illuminated pupils constrict simultaneously. Pupil opposite the one illuminated constrict simultaneously. Abnormal findings, dilated pupil 6 to 7 mm, the patient have oculomotor nerve paralysis. Second, constricted pupil unresponsive to light or accommodation, the patient have lesions of the sympathetic nervous system. And lastly, unilateral dilated pupil unresponsive to cranial nerve number 3. Test for cranial nerve number 5, trigeminal. Instruction, first, test motor function. Ask the client to clench the teeth while you palpate the temporal and masseter muscles for contraction. Clinical tip, this test may be difficult to perform and evaluate in the client without teeth. Normal findings, temporal and masseter muscles contract bilaterally. Abnormal findings, decreased contraction in one of the both sides. Asymmetric strength in moving the jaw may be seen with lesion or injury of the 5th cranial nerve. Pain occurs with clenching of the teeth. Second instruction, test sensory function. Tell the client, I am going to touch your forehead, cheeks, and chin with the sharp or dull side of the paper clip. Please close your eyes and tell me if you feel a sharp or dull sensation. Also, tell me where you feel it. Vary the sharp and dull stimulus in the facial areas and compare sides. Repeat test for light touch with a wisp of cotton. Normal findings, the client correctly identifies sharp and dull stimuli and light touch to the forehead, cheeks, and chin. Abnormal findings, Inability to feel and correctly identify facial stimuli occurs with lesions of the trigeminal nerve, of lesions in the spinothalamic tract or posterior columns. Third instruction, test corneal reflex. Ask the client to look away and up while you lightly touch the cornea with a fine wisp of cotton. Repeat on the other side. Clinical tip. This reflex may be absent or reduced in client who wear contact lenses. Normal findings. Eyelids blink bilaterally. Abnormal findings. An absence of corneal reflex may be noted with the lesions of the trigeminal nerve or lesions of the motor part of cranial nerve number 7, the facial. Test for cranial nerve number 7, facial. First instruction, test motor function. Ask the client to smile, frown, and wrinkle forehead, show teeth, puff out cheeks, purse lips, raise eyebrows, close eyes tightly against resistance. Normal findings, client smiles, frowns, wrinkles forehead, shows teeth, puffs out cheek, purses lips, raises eyebrows, and closes eyes against resistance. The movements are symmetric. Abnormal findings, inability to close eyes, wrinkle forehead or raise forehead, along with paralysis of the lower part of the face on the affected side is seen with Bell palsy. Paralysis of the lower part of the face on the opposite side affected may be seen with a central lesion that affects the upper motor neurons, such as from stroke. Second instruction, sensory function is not routinely tested. If it is, however, touch the anterior two-thirds of the tongue with a moistened applicator dipped in salt, sugar, or lemon juice and ask the client to identify the flavor. If the client is unsuccessful, repeat the test using one of the other solutions. If needed, repeat the test using the remaining solution. Clinical tip, make sure the client leaves the tongue protruded to identify the flavor. Otherwise, the substance may move with the posterior two-thirds of the tongue, the vagus nerve innervation. The posterior portion is tested similarly to evaluate function of cranial nerve number 9 and 10. The client should rinse the mouth with water between each taste test. Normal findings, clients identify correct flavor. For older adult client considerations, in some older adult clients, the sense of taste may be decreased. For the abnormal findings, inability to identify correct flavor on the anterior two-thirds of the tongue suggests impairment of cranial nerve number 7. Test for cranial nerve number 8, acoustic or vestibulocochlear. Instruction, test the client's hearing ability in each ear and perform the Weber-Andernatt test to assess the cochlear or auditory component of cranial nerve number 8. Normal findings, client hears whispered words from 1 to 2 feet. Weber test, vibration heard equally well in both ears. Rene test, air conduction is twice as long as bone conduction. For the abnormal findings, vibratory sound lateralizes to good ear in sensorineural loss. Air conduction is longer than bone conduction, but not as twice as long in a sensorineural loss. Test for cranial nerve number 9, glossopharyngeal and cranial nerve number 10, vagus. First instruction, test motor function. Ask the client to open mouth wide and say ah while you use a tongue depressor on the client's tongue. Normal findings, uvula and palate rise bilaterally and symmetrically on phonation. Abnormal findings, soft palate does not rise with bilateral lesions of cranial nerve number 10, vagus. Unilateral rising of the soft palate and deviation of the uvula to the normal side are seen with a unilateral lesion of the cranial nerve number 10. Second instruction, test the gag reflex by touching the posterior pharynx with a tongue depressor. Clinical tip, Warn the client that you are going to do this and that the test may feel little uncomfortable. Normal findings: gag reflex intact. Some normal clients may have a reduced or absent gag reflex. Abnormal findings: an absence of gag reflex may be seen with lesions of cranial nerve number 9 or 10. Test for cranial nerve number 11. Spinal accessory. Instruction: ask the client to turn the head against resistance, first to the right, then to the left, to assess the sternocleidomastoid muscles. Normal findings: there is a strong contraction of the sternocleidomastoid muscles on the side opposite the turned face. Abnormal findings: atrophy with fasciculations may be seen with peripheral nerve disease. Second instruction: ask the client to shrug the shoulders against resistance to assess the trapezius muscles. Normal findings: there is a symmetric, strong contraction of the trapezius muscles. Abnormal findings: asymmetric muscle contraction or dropping of the shoulder may be seen with paralysis or muscle weakness due to the neck injury or torticollis. Test for cranial nerve number 12, hypoglossal. Instruction: to assess the strength and mobility of the tongue, ask the client to protrude tongue, move it to each side against the resistance of a tongue depressor, and then put it back in the mouth. Normal findings: tongue movement is symmetric and smooth, and bilateral strength is apparent. Abnormal findings: fasciculations and atrophy of the tongue may be seen with a peripheral nerve disease. Deviation to the affected side is seen with unilateral lesion. Nursing responsibilities before, during, and after cranial nerve assessment. Before, check the physician's order to ensure that this procedure is ordered by the physician and to make sure that it is the right client. Gather the necessary equipment to save time and energy. Wash hands and observe appropriate infection control procedure. To practice aseptic technique and to adhere to the principle of microbiology to prevent from cross-contamination. Bring the tray with all the materials to the patient's bedside to provide an easy access upon getting the materials and to save time and energy. Make a brief survey to determine the client's ability to participate and ensures that the room is warm and free of drafts with full lighting. And explain all the procedures to the client and identify the client to reduce anxiety and to establish rapport so that the patient will know about the process that will be done to him or her. And lastly, instruct the client to get into a comfortable position. Nursing responsibilities during the cranial nerve assessment. First is to ensure client privacy and safety, to protect the dignity of the client. And always ask before touching the client, in order for the client to be aware of what procedure or test you are doing. And assess cranial nerves properly and work in an organized manner from cranial nerve 1 to cranial nerve 12. And always monitor client's responses throughout the assessment. And monitor client's level of comfort throughout the assessment. Nursing responsibilities after the cranial nerve assessment. First is to always record or document findings from cranial nerve assessment for evaluation and medical legal purposes, and then review and validate all findings before assisting the client with dressing, if necessary, to recheck any information or gather additional data, and always assist the client to resume a comfortable position to promote comfort and to avoid from any injuries, and report severely abnormal findings to the physician. And lastly, do aftercare to prevent from any contamination in the area. So thank you for watching and listening. Have a nice day, everyone.